Good afternoon, everyone. Thank you so much for joining us here today. My name is Megan Williams, and I am the Director of Support Services at Alzheimer Group. If you're joining us for the first time, AGI is a charitable organization that supports families and people living with dementia. Some of the services that we offer include programming for people living with dementia, counseling, support groups for caregivers, and different education courses. Today's lecture is being made possible thanks to the generous support of the Lindsay Memorial Foundation and the Lasner Learning Center. For today's lecture, we will be discussing brain scans and tests. What do we really mean when we talk about dementia? I'd like to introduce you to our guest speaker, Dr. Paolo Vitali. Dr. Vitali is a certified neurologist and neuropsychologist. He is an assistant professor at the McGill University Department of Neurology and Neurosurgery Faculty of Medicine. He is a staff neurologist at the CIUS Ouest de l'Île de Montréal and at the McGill University Research Center for Studies in Aging. Dr. Vitali is mainly involved in the evaluation and the follow-up of patients with neurodegenerative diseases, in particular, atypical dementia with language disorders. He is a researcher in clinical trials on Alzheimer's disease, and he is also a clinical supervisor of PhD students in neuropsychology. So, Dr. Vitali, I'd like to thank you so much again for agreeing to present today. If anyone has any questions, we will be answering them at the end of the lecture. You can use the Q&A function or the chat function at the bottom of your screen, and we will address them as long as that we have enough time. So, Dr. Vitali, the floor is yours.
Thank you, Megan. Thank you for the invitation. Thank you to AGI for this kind of invitation and introduction. So, Happy New Year to everyone. I can see you, but I know you are there. So, if you have any questions, just let us know. It will be my pleasure to answer during the talk or at the end. No problem. So, I don't have any potential conflict of interest related to this presentation, but just to let you know, I'm involved in clinical research and clinical trials at the Douglas at the MNI for medications against Alzheimer. So I've been asked to talk a bit about some of these common questions that usually caregivers can ask, and most of them are related to the use and utility and of brain scans, and how and when, who is supposed to have a scan, and what we are looking to the scan. So we are going to have a look at this as a general view. I don't go through the details of all of this, but I would like to have to let you some time at the end to answer all your possible questions. So before, I would like to make some clarification about important terms that we are using in the neurodegenerative and dementia field. First of all, there is a kind of change in the terminology. What we maybe are used to call dementia now is we prefer to call a major neurocognitive disorder. I think there are people tend not to like too much the term dementia. And we refer to MCI, or mild cognitive impairment, now as a minor neurocognitive disorder, in which there are still cognitive difficulties, but less severe than in major neurocognitive disorder and without functional impairments. And another frequent question that I usually have from my patients is, which is the difference between dementia and Alzheimer's disease? And you have to know that dementia is not a synonymous of Alzheimer's disease. We are going to explain this a little bit later. So dementia is not a synonymous of Alzheimer's disease. And just to clarify, major neurocognitive disorder, dementia, or Alzheimer's disease, they are not part of the normal aging. So it's not a kind of unfortunate and extreme stage of normal aging. Dementia and major neurocognitive disorder and Alzheimer, there are specific pathology of the disease of the brain, which peculiar and specific abnormalities that we can see in the brain of people suffering from Alzheimer. Okay, so what is major neurocognitive disorder? What does it mean? These are the criteria from the National Institute of Aging Alzheimer Association from 2011 from US, and they decided diagnostic criteria for a major neurocognitive disorder. So it represents a decline from previous functional level due to cognitive difficulties. So dementia is characterized by cognitive difficulties, meaning difficulties in memory, language, visuospatial, planning, organization, inhibition, behavior. So all the cognitive functions which let us operate in the world. So there should be a decline, objective decline in cognitive function with some impairment on the daily functional level. So usually we measure this with some decline in functioning at work or on usual activities, activities of daily living, like grocery, financial, driving, hobby, and all of these kind of things, and ultimately also a decline in a more basic activity of daily living, like dressing, eating, bathing, and etc. Major neurocognitive disorder should not be due to some acute medical condition, like a kind of delirium, or from psychiatric disorder, like major depression, anxiety, schizophrenia. So it's different from a psychiatric condition. And the diagnosis is really based on clinical history and neurological examination. So this is a clinical diagnosis. For sure, we are going to ask scans, blood workup, and other peculiar tests, but basically the diagnosis is a clinical diagnosis. By dementia, we usually think at a kind of an umbrella term for a different brain disease. Under this great umbrella of major neurocognitive disorder or dementia term, we can see different types, different form of neurodegenerative conditions. For sure, Alzheimer is the most frequent form of dementia, but it's just one type, one form of dementia. There are other forms, other type of neurocognitive disorder, like vascular dementia due to a bunch of strokes, mixed dementia, in which you can have a combination of Alzheimer and vascular, or other rarer form of a major neurocognitive disorder like frontotemporal dementia, Lewy body, or other Parkinsonian dementia, Huntington disease, Wernicke-Korsakoff syndrome, in which the alcohol abuse, the chronic alcohol abuse is involved, normal pressure hydrocephalus, in which there is a high pressure in the brain, and also Creutzfeldt-Jakob disease, which is quite rare. So we are talking about major neurocognitive disease and the different type of disease, brain disease, we can provoke and cause major neurocognitive disorder. But as I already said, for sure, as you know, Alzheimer is the most frequent. So how we define Alzheimer's disease? Alzheimer's disease is a kind of dementia, so we have to have a decline in cognitive abilities with some functional impairment. This is the basic definition. For sure, this cognitive impairment should be insidious in onset. It's not all at once or sudden. It's more insidious and gradual, progressive over months and years. This is the specific characteristic of this kind of major neurocognitive disorder like Alzheimer. And it is characterized principally, mainly by an important memory deficit. So the inability to gain and retain new informations from the environment. This is the classic feature of amnestic or memory variant of Alzheimer's disease. Now we well know that there are other atypical forms of Alzheimer's disease characterized more by language impairment or visuospatial difficulties or even behavior or neuropsychiatric features. But the most frequent, again, is the memory form. And for sure, when we consider a diagnosis of probable AD, probable Alzheimer, we have to rule out other different brain disease, other different forms of neurodegenerative disorder like those I talked to you before. Just a few data regarding major neurocognitive disorder and in particular Alzheimer. It's very frequent. It's more than 1.5 million Canadians are affected by this disorder. We don't have to neglect the early onset Alzheimer disease patients in which symptoms presented before age 65. The number of AD patients are expected to double over the next 20 years. Most of them are and will be women. So we don't know exactly why, but there is probably a hormonal effect. But also, for sure, women tend to live longer than men, and as age is the major risk factor for developing Alzheimer, so it's not unexpected that women will be more affected. We expect 25,000 new cases per year, and just a matter of fact, if you are a smoker, you have almost 50% more chances to develop major neurocognitive disorder compared to non-smoker. Alzheimer has been termed as a major killer. So this is the definition of the end of last century. And we really know that today people die for it. Ultimately is a dead disease. We can see here from statistics that compared to other selected causes of death, Alzheimer's disease, the only one was the mortality is actually increasing compared to stroke or heart disease or even cancer. So it's a major social and economical issue in our society. So before talking about the scans and the other test, I would like to bring you through the journey of the diagnosis of motor neurocognitive disorder briefly. It's not going to take so much time, but if someone has cognitive complaints in terms of memory, language, or disorientation, or behavioral issues, for sure that he or she should talk to is GP, and importantly, he should be accompanied by a significant informant to have a more precise information about what's going on. For sure, the GP is going to use some cognitive screening tests like MoCA or Mini-Mental, sometimes with the help of a nurse. People also can be asked to fill some forms regarding autonomy on activity of daily living or on mental health, like question regarding mental health, hallucination, delirious, or depression symptoms, or anxiety symptoms. For sure, the GP will review the medical history and other medical conditions, in addition to education, professional, and family history. A neurological exam will be done, particularly with the focus on eye movements and reflexes and balance. If there is, just to verify there is no evidence of previous strokes, for example, or other form of neurodegenerative conditions which can affect mainly the motor skills, like Parkinson, for example. At this point, a referral to a memory clinic or a cognitive specialist like a neurologist, a geriatrician, or a psychiatrist may be required, but it's not always necessary. Usually a classic case of a typical AD patient or patient living with major neurocognitive disease can be actually well managed by primary GP. As I say, oops. Can you hear me?
Yep, we can hear you.
I don't know what happened. Just
it's going backwards.
Sorry, I had just problem with my presentation. Do you see it now?
Yes, we can.
Okay, sorry, I don't know what happened. It was all black on my screen. So I would say that diagnosis is usually done, is a clinical diagnosis. So usually the diagnosis has been done through medical history, cognitive and psychological assessment, and with the help of some cognitive screening tests. So at the end of this first appointment, the GP should be able to say if the cognition is normal, or there is some mild cognitive impairment or minor neurocognitive impairment, as I told you, or whether there is some major neurocognitive disorder or dementia. Sometimes a neuropsychological assessment could be asked for a longer battery of cognitive tests, precisely measuring your memory, language, and other cognitive skills. This can be done to have an appropriate look at your autonomy and cognitive functioning, and to help in clarifying diagnosis and capacity. At this point, the physician can usually ask for some blood workup and a brain CT, but it's not, even at this point, it's not always necessary. When the symptoms are very typical, we can sometimes, but rarely, we can just hold them and stop there the investigation and start medications. And other more fancy or more rarer analysis could also be done in accord to the general assessment by the GP. So when does someone need a scan? So this is the focus of the presentation. And as I said, not everyone is usually asked to do a scan, a CT head, but in accord to the last recommendation from the Canadian Consensus Conference group on the diagnosis and treatment of dementia, anatomical neuroimaging is usually recommended in most situations, even in older subjects. Before, for older subjects, usually it was not necessary, it was not recommended to perform an anatomical neuroimaging in all the cases. But now we tend to do it, especially in when there are those list of indications. when the cognitive symptoms lasted less than 2 years, regardless of the rate of progression, when there is some unexpected or unexplained decline in cognition or functional status in a patient already known for dementia. So when this kind of progression is unexpectedly faster than expected, we can ask a scan. When there was a recent and significant head trauma, then when there are unexplained neurological manifestation like a new onset severe headache, seizure, or signs of stroke on the neuro exam. This can be done at onset or during evolution. When there is an history of cancer, especially when this cancer can give a brain metastasis, then the subject is at risk for intracranial bleeding or is on anticoagulation treatment like warfarin, coumadin, or Xarelto, Eliquis, or this kind of newer anticoagulation drug. When there are symptoms suggestive of normal pressure hydrocephalus, and when there are significant vascular risk factors like high blood pressure, cholesterol, diabetes, long-lasting history of smoke or drug abuse or alcohol. So all of this. So basically, we tend to do a scan to everyone. Honestly, in my practice, in my specialized practice, it's extremely rare I don't do a structural imaging of the brain to my patients. And why does someone need a scan at this point? Oh, it's a simple question, because the aim is to rule out structural and potentially treatable conditions. For example, meningiomas, bleeding, stroke, or other condition which can be addressed medically or surgically. As you know, cognitive impairment are not due to a single cause, but many other neurodegenerative and not neurodegenerative disease and condition can ultimately provoke cognitive impairment. And we can grade this on a time scale from and divided in acute, subacute, or chronic onset. When we talk about acute onset, we meaning seconds to days. And we usually add this in a situation where we have to think about cerebrovascular accident or stroke, head trauma, brain infections like meningitis, encephalitis, some metabolic abnormalities, meaning impairment in kidney functions, liver function, or thyroid problem, electrolytes imbalance. So this can be, all this can give you cognitive difficulties acutely in terms of seconds to days. When we go to subacute phase, so progression over weeks to months, usually we should evoke some medications issues like Ativan or other benzodiazepine, narcotics, bladder medications, brain cancer, metastasis, epilepsy, chronic epilepsy, or chronic long-lasting alcohol abuse can give us chronic cognitive impairment. And when we think the progression in terms of years to decades on the chronic phase, we have to think about chronic psychiatric conditions like schizophrenia or chronic depression or other psychiatric condition, or neurodegenerative disease, for example, Alzheimer's. What are the different scans now? Basically, for what concerns the structural imaging, meaning the scans able to see the anatomy of the brain, we usually ask for CT scan or brain MRI. The advantage of CT scan are that this technique is less expensive, shorter waiting list, more accessible all through the Quebec. It's a faster exam, couple of minutes, maybe 10 minutes. It's also possible for claustrophobic or very heavy patients. And it's also fine with patients with a pacemaker or other implantable devices. MRI, on the contrary, is good because there is no radiation, and it presents higher sensitivity to for lesion or vascular lesions or other disease in the brain, structural disease in the brain, like cancer or even infections. We tend to, in our specialized clinic, we tend to prefer, and it's recommended to do an MRI over a CT head. However, in common clinical practice, in general clinical practice in the GP office, usually a simple CT head is asked before referring the patient to a memory clinic. I just want to show you an example here of what the difference between the two neuroimaging modalities. So on the left, you see a simple CT head. Actually, this is from the same patient. Okay, so on the left, a simple CT head. And on the right, an MRI of the same patients, and you can see here in the center these two ring-enhanced lesions, which actually are brain tumor. And as you see, you can see on the correspondent image from the CT head. So the MRI provides definitely a better picture of the brain. And it's reasonable to ask for an MRI when we think, first of all, of some structural lesions responsible for the cognitive difficulties. Actually, with this patient presented with a subacute history of confusion and language impairments. And actually, it was not dementia, it was a brain tumor. So what we look for in a CT scan or MRI in people living with dementia. This is somehow reserved to neurologists or other health professionals specialized in neurodegenerative disease. There are a few features that we would like to see in the scans. The first one is the atrophy of a specific structure in the brain. I show you here in the yellow square. This is the hippocampus. The hippocampus is a specific region, organ of the brain, which is responsible of the memory. So is the organ of the brain where is involved in acquiring new novel information from the environment. And as you know, Alzheimer is mainly a disease of memory. And it's not surprising that we can see an atrophy of this specific structure of the brain, the hippocampus. Usually at the beginning, is almost normal, but with the progression of the disease, we see a shrinking. So a progression, atrophy, loss of volume of this specific structure. We can trace this over time. So this is one of the first important things we want to see in scans. The other one is the white matter disease. So you can see here this on the MRI. Those white matter. So this white spots on the brain, especially on the third row. And we term this leukoariosis, or chronic microvascular disease. You maybe have heard about this. It's quite frequent when you do a scan or MRI to have this information on the final part of the report from the radiologist. What does it mean? This is considered to be due to chronic small vessel disease. So, you know, in the brain, there are big vessels and small vessels bringing the blood toward the most deeper structures in the brain. And following vascular risk factors, those small vessels tend to be occluded over time and with aging, giving this appearance on the MRI of white spots, which can be very sparse and rare, or progress over time to a more diffuse and confluent pattern, as we see on the fourth row. This alone can contribute to cognitive deficits. Is not related to Alzheimer's disease, but can exacerbate, can increase the memory and other cognitive difficulties in patients with living with dementia. So if you have a normal MRI with no evidence of white matter disorder, usually people perform better on cognitive tests, even if they are affected by Alzheimer's disease. On the contrary, if they have severe, moderate to severe white matter abnormalities, like the third line, we can observe an exacerbation of worse cognitive deficits. And finally, the third element that we want to look on the MRI, specifically on MRI, is the focal pattern of atrophy. Usually, we read on the report that there is a kind of global, non-specific, diffuse atrophy of the brain in people living with dementia. Sometimes not, but sometimes yes. But what we are interested is not this global diffuse atrophy. We are more interested in specific region where the atrophy is more significant. For example, there are dementia like frontotemporal dementia, which is different from Alzheimer, where we can find atrophy specific in the frontotemporal region, so in the frontal and temporal region of the brain. And there are very specific for this kind of dementia, the frontotemporal dementia. We didn't find it in Alzheimer's disease. This can help in doing the right diagnosis of frontotemporal dementia instead of incorrectly diagnosis someone with Alzheimer. Here on the bottom part of the screen, you see another patient with a significant atrophy of the left part of the brain, the temporal pole of the brain on the left. And this is very suggestive and characteristic of semantic dementia, which is another different from Alzheimer's form of neurodegenerative disorder. So by looking at the specific pattern of regions of the brain which are atrophic, meaning with less volume, we are able to correctly identify different forms of neurodegenerative disease. So that's very important for us. So this is the third features that we usually look when we ask at a structural MRI or imaging. There are other important types of scan. Now, I've talked about the structural imaging. Now we are going to discuss briefly the functional and molecular neuroimaging. So we are not interested here in the picture of the brain, but we are interested in how the brain works, which are the region of the brain which are more or less active. For example, when we ask for FDG PET scan, we are very interested in the metabolism of the brain regions, and there are regions which are less or more active in neurodegenerative condition. This is a very frequent test we usually ask in memory clinics. We can see here, for example, there are specific pattern of hypometabolic regions for specific disease. For example, Alzheimer's disease is classically characterized by a loss of diminished perfusion, metabolism in the bilateral posterior parietal brain regions. So when you observe a scan with this kind of pattern of hypometabolism, this is very suggestive of Alzheimer's disease compared to other form of neurodegenerative disease, where, for example, in frontotemporal dementia, we see a diminished metabolism in the frontal, so in the more anterior part of the brain. Again, this can help us in correctly diagnosis patients, and we tend to use it in complex cases or to identify a neurodegenerative etiology or to orient the differential diagnosis. Let's do an example. For example, we have a patient with chronic, long-lasting chronic severe depression or schizophrenia, now presenting for the last couple of years of new or progressive cognitive disorders. Is this due to his or her chronic psychiatric condition, or is this due to somehow a new brain disease like Alzheimer's disease? So clinically, it's quite different, quite difficult to differentiate between these two patterns. It's not impossible, it's somehow difficult. So we can use this exam to orient us in the right diagnosis. I forgot to mention this is an exam which requires an infusion, a contrast product to be obtained, but it's very safe, good sensitivity, and relatively non-invasive. However, it's very costly. It can cost several $1,000s. And there is significant radiation exposure, and the interpretation is based on the experience of the radiologist. So we can have somehow different interpretations from different radiologists in accord to their experience. There are other newer form of scans now. Maybe you heard about them, the amyloid PET scan and the tau PET scans. These are scans which are based specifically on the pathophysiology of Alzheimer's disease. You are maybe aware that the Alzheimer's disease is due to the accumulation in the brain of two important proteins, which are abnormal in the patients living with Alzheimer: the amyloid plaque proteins and the tau proteins. And until a few years ago, we were not able to to see these proteins in the living brain, so in people living with Alzheimer's, but it was only possible to observe these abnormal proteins during an autopsy, so when the patient would die. But now we are able to see clearly this abnormal accumulation of proteins in vivo, meaning in patients living with cognitive disease. And you can see here in red on the images the accumulation in the cortical region, so in the brain, of the amyloid plaques, which is one of the two important proteins of the Alzheimer's disease patients. We have to say something about this. Amyloid accumulation is also observed in normal people, so it's not unusual. I would not be surprised if we do an amyloid PET scan to us now. For sure, many of us will be some form of this amyloid. What does it mean? It means that we don't have necessarily Alzheimer, but we have at risk to develop Alzheimer. However, there are also people who die without dementia and without Alzheimer, and when we perform an autopsy on their brains, there are accumulation of amyloid, but no dementia, no cognitive difficulties. So it's important test, but it's not the only one we need. But it's kind of game changer, because it's very important, for example, to have this test done, to recruit a patient for clinical trials, for example, for medication against Alzheimer. The other one is the tau imaging. Again, the tau protein is the other important protein which is abnormal in patients living with Alzheimer. And again, in red and brilliant white here, you can see the accumulations of specific tau in specific regions of the brain. And usually tau accumulation is significantly associated with cognitive deficit compared to amyloid. Amyloid could be diffuse in the brain without cognitive symptoms, but if you have tau accumulations in specific regions of the brain, you have almost for sure cognitive difficulties. For example, if you have accumulations of tau in the region subserving language function, which usually is on the left side of the brain, you will have aphasia, so difficulty with language, because of the accumulation of tau protein in these specific regions. Why is a scan important? So this is a kind of resume of what I just said. If the brain has a problem, let's have a look at the brain. This is the first important thing to do. There are a few treatable conditions which can be easily detected by a simple CT scan. However, maybe you're aware that sometimes the GP, the doctor say, oh, the scan is normal, but the patient still have symptoms suggestive of probable Alzheimer's disease. What does that mean? As I say, the major neurocognitive disorder and Alzheimer are basically a clinical diagnosis based on neuro exam and history. However, experienced memory clinician can look for important features in scans to help with the diagnosis, as I show you in the last slides. And finally, amyloid and tau scans can now detect AD pathology in living persons, and this is fundamental for patients to be recruited in anti-AD clinical trials. This is my last slide. I talk about scans, but we are now able to perform also a lumbar puncture. Lumbar puncture is a safe procedure. We usually do is an outpatient setting in our clinics. Is a puncture in the lumbar spine where the spinal cord is no longer present. There are just the accumulation of cerebrospinal fluid in the spinal canal. And it's very simple, safe, in most cases, painless procedures. It's due under local anesthesia. And it allows to collect some of the cerebrospinal fluid that surrounds the brain and spinal cord. Why we do this? Because, as I said before, the two proteins which are abnormal in AD, so the amyloid and tau proteins, which are now, we are now able to detect them also in the cerebrospinal fluid surrounding the spinal canal, the spinal cord. So we are able to collect a few cc of the cerebrospinal fluid and send for analysis in the US to have the results and to look for the abnormal accumulation of those abnormal proteins. This procedure is less expensive than scans, and there is no irradiation associated. And we will be soon able to do the same test, but on the blood, so without the discomfort of the lumbar puncture. So in the next future, is already available in the research settings, but in the next future, we will be able to offer this this analysis also in the blood, and ultimately is let us to have a more precise diagnosis, especially for Alzheimer disease. So I have finished here. I think we have good time for questions, if you like.
Thank you, Dr. Vitali. I think just seeing the images that you showed in your slides really clarify a lot of things. So please feel free to write any questions that you have in the chat or the Q&A function. I just wanted to know about the process of having these scans and the MRI and everything. You know, knowing, having lots of interactions with people living with dementia, how challenging is it for families to go through that process to prepare them for these scans?
I think the major problem here is a very good question, Megan. It's a very good question. Thank you for asking, because it's a very important topic for caregivers and patients. I agree. Yeah, it's. I think the process for having a scan is not. I mean, just the exam itself, it's not difficult. It's not demanding. For a CT head and MRI, there is no preparation to do. I think the major issue is to have an appointment. I think the major issue is having up. There are hospital or clinics where is easier to find a place, to find a spot. There are hospitals which are where they to obtain the scans is more difficult, it takes longer. Usually we can also ask for some modulation of urgency. So I can say, I would like to have this scan in the next month or 2 months. We can do this as a physicians. We can also ask for the scan in a specific hospital where we know it's going to be easier to obtain. So we know this kind of things in our clinic, the McGill Center for Studies on Aging. But usually we say the MRIs takes some more times, more expensive. There is more a longer waiting list. But usually you can have this exam in a couple of months. You would say 2 to 3 months is expected to obtain this. The PET scan, the FDG PET scan, it's usually done at the CHUM. We do at the CHUM downtown. There are other places. There is a Maisonneuve Rosemont. There is at the Glen. We particularly love to work with the CHUM because there is a very well-known radiologist working there with a good expertise in neurodegenerative disease. So we would like to refer our patient there. Yeah, again, there is the PET scan. There is some injection of contrast product. There should not be any contraindication to that, but it's a safe procedure, and usually it doesn't take in so much preparation for that.
Okay, and if for some reason, I know this is kind of the logic, but if for some reason it's not a good day for the patient, you know, they're they woke up and there's different symptoms or behaviors that just wouldn't be the best day for the scan, would they have to go to the bottom of the list? Do you know that information? Or could that be easily rescheduled?
I don't think so. I think that the most important thing to do in these cases is to call the hospital, to call the clinic, and to let them know that the patient is not doing well, that they're still interested in doing the exam, because there are some politics in the hospitals. If you miss 2 or 3 appointments without explanations, it depends. Sometimes it's 2, sometimes it's 3, depends on the politics of the. Yeah, if you don't show up and you don't give an explanation for that, you risk to be clearly excluded from the waiting list. But if you call and you have a good explanation, I think they could try to reschedule sooner. Yeah.
Okay.
This is my experience.
Okay, good. And of course, every place is different. One of the questions that I see written is about the frequency and the follow-ups of having, MRIs. So someone was diagnosed with MCI, and they had an MRI, and there was no findings, conclusive findings for the MRI. Is it important to get a regular MRI following that to track any brain changes from the MCI diagnosis?
Excellent question. I would say it's not necessary. It's not mandatory, and usually we don't do. As I said, the MRI and scan are usually done to rule out lesions, to rule out structural abnormalities, tumor, meningiomas, ancient strokes, high tension, high pressure in the brain, this kind of disease. If everything is normal, I told you about some specific features we would like to see, but it's not necessary to do regularly. It's not my clinic in any way. Sometimes in research settings, yes, you can have serial MRI or serial PET scan or serial tau and amyloid scans, but this is research settings. We want to see the progression of the anatomical subtleties, changes over time in patients with MCI or patients living with dementia. But in regular clinical, not research-based practice, when the first MRI is done, it's not common practice to ask again, unless there are new symptoms, new focalized symptoms like seizures, signs of stroke, new severe headache, head trauma, bleeding, risk factors. So if there is something new, yes, we are going to ask a new neuroimaging. But if everything is stable and there are no change except a minor progression of memory complaints, we tend not to do another scan.
Okay. A couple of questions. Just I'm aware of the time. Just to let everyone know that this is recorded and you will be sent the recording. So those who are looking to follow up with the slides and so forth, Dr.
Yeah, I have a
Vitali.
few minutes more. I have 10 minutes more if you have.
Okay. Okay.
No
I just want to clarify that for everyone. Francine says if a CT scan shows shrinkage, relatively normal shrinkage of the brain without tau and amyloid, yet other tests showed cognitive issues, how do you know it's really Alzheimer's disease?
Good point. Yeah, for sure. As I said, Alzheimer's disease is a clinical diagnosis. There are criteria, as I say, progressive memory issues, gradual onset, functional impact. This is a clear phenotype features of Alzheimer's disease. When we look at the brain, at autopsy, and people with this kind of gradually progressive memory impairment with functional decline, we usually, most of the time, observe AD pathology in the brain. So we can just say this is probable AD due to the manifestation of the disease. However, now we are able to provide evidence in vivo of AD pathology. by doing the amyloid scan and tau scan. If amyloid scan and tau scan are negative, so there is no Alzheimer. The cognitive difficulties are due to something else, due to other disease. It could be vascular, it could be frontotemporal dementia, could be other form of dementia. But again, if there is just some shrinking of the brain and the phenotype is very consistent of AD, you can just stop there and say, okay, this is probable AD, or you can go further and go in a specialized clinic to have additional workup, including amyloid and tau scans or lumbar puncture. It's the same that give us approximately the same informations. And these new further tests are positive for AD, so we have the pathological evidence of the underlying AD pathophysiology.
Okay, thank you. Do you have any more information about the blood tests for the future and what they're going to show?
Yeah, I don't know exactly when, but we usually use it. We regularly use it in the clinic, in the research setting at the MCSA, the McGill Center of Studies in Aging, at McGill, and there are some again. We usually send this blood to Europe to be analyzed. We are not still able to do on the place. I can give you a timeline, exact timeline for this, but I would say a couple of years should be present in the clinical practice. I would say, but it's not for everyone. Huh? I think we have to target the right person, the right symptoms, and what we should decide what we are going to do with this information. Because if you do a blood test in a patient of 50 years old, for example, which is normal, working, and with family and whatever, and there is evidence of AD pathophysiology, what we do with this result. So this should be done in people who are willing to participate, for example, in research for AD drugs, or when a new medication against AD will be available in Canada. As you know, there are new medication in the US, but they are still not available in Canada. Maybe, hopefully, in accord to someone, and not hopefully in accord to other, will be available in Canada soon. We will see.
That's a whole, the medication, that's a whole other lecture.
Yeah, I don't know if you want to open this.
I don't know if I want to open that, but we could have a part two, absolutely. The lumbar puncture is not typically done in older people.
Sorry, say it again?
The lumbar puncture, it's typically done in younger people than older people?
Yeah, that's right.
And why is that?
It depends. Usually it's recommended to be done in younger people. Good question. Huh? Younger people less than 65 or less. Or people who are presenting with atypical presentation, not classic memory deficit, more language, visuospatial behavior, presentation of neurodegenerative disease or major neurocognitive disorder. However, in my practice, I like it very well, and I tend to perform in people who are interested in doing to go further in the diagnosis process. If they really want to know if there is a neurodegenerative and typically AD pathophysiology, I propose a lumbar puncture to them if they want to.
Okay, thank you. And just one last question. We have curious minds. Who is the largest funders in Canada of neurological research on Alzheimer's disease?
I think in Canada, MCSA McGill is well placed. It's very well placed. For sure, in Quebec, we are on the top. In Canada, there is Toronto Baycrest Center is very well known. Yeah, I think. To my knowledge, there is in Vancouver, there are another center which is very active, but we will say Toronto and our center, they are kind of very active in AD research and clinical trials.
Okay, Dr. Vitali, thank you so much. I think I've seen lots of comments. Thank you for the presentation. It's wonderful, it's clear. And I think you're just helping to clarify some of the questions that people have, but maybe don't have the opportunity to ask. So thank you for that. I just wanted to acknowledge that this is Alzheimer's Awareness Month, and AGI is hosting an Alzheimer's Awareness Seminar on January 25th, and it's called Loving Each Other Through the Dementia Journey. It's essentially about how to maintain close bonds with the person you're caring for. It will be a little bit interactive, but if you want any information, you can give us a call at AGI. Again, Dr. Vitali, thank you so much for your time. I know it's very busy for you, so we really do appreciate it at AGI.
Thank you very much, Megan. I really enjoyed this time with you. And if you have any further questions, do not hesitate to write me or Megan, and I can answer, no problem. It's my pleasure.
Yeah, we can connect. If you have any questions, you can always write AGI, and then I can connect them to Dr. Vitali. So thank you. Have a wonderful day. Take care, everyone.
You too. Thank you.
Bye-bye.
Bye to you, everyone. Bye bye.